We undertook this review because obesity has become a major barrier to accessing kidney transplantation. Yet there was no existing synthesis of how patients and clinicians experience obesity management in kidney failure prior to transplantation. So obesity is highly prevalent among people living with kidney failure, and many are asked to lose weight to meet transplant center BMI thresholds, criteria that can exclude up to 30% of otherwise eligible candidates. At the same time, there's limited evidence on the effective, safe weight management strategies for people on dialysis who face profound challenges from previous data such as hunger, fatigue, and restrictive dietary requirements, making it challenging to lose weight. So we recognized a clear gap in the literature. No prior review had brought together both patient and clinician perspectives to understand how these barriers, expectations, and systematic inconsistencies shaped real-world transplant access. So our goal was really to highlight these lived experiences to drive more equitable and practical approaches to obesity management in this population. Lived experience is absolutely key to understand, both from the patient's but also the clinician's point of view. So when we looked at all the studies, a powerful story emerged about the struggles, strain, and misalignment in current obesity management for people waiting for transplantation. Patients described an exhausted reality. Dialysis left them hungry, fatigued, and making weight loss efforts nearly impossible. They struggled actually with the conflict between weight-specific dietary restrictions and weight loss advice, often feeling frustrated, under-supported, or judged. Many also internalized the negative beliefs about their weight held by society, blaming themselves for not losing weight and actually doing enough to lose weight themselves. Clinicians, meanwhile, expressed their own challenges. Many felt that they lacked training and knowledge about obesity, or were unsure how to safely support people to lose weight. They described competing clinical priorities, limited time, uncertainty about when and how to raise a conversation about weight, which isn't just exclusive for kidney failure, and particularly within a busy public and sometimes cognitively taxing dialysis environment. Together, these narratives show a system where both sides face barriers about weight loss, yet a lack of structure and support needed to navigate obesity management effectively and also compassionately. Is highly prevalent within our society. It's prevalent in education, it's prevalent in media, it's prevalent, unfortunately, also in healthcare. And what we know from previous data is that that stigma towards someone of a higher body weight can impact their access to care. Our review found that weight stigma and BMI-based transplant criteria combined to create a significant inequalities to access to transplantation. Some clinicians held negative stereotypes about patients with obesity, describing them as quote unquote unmotivated, quote unquote childlike, or unfortunately quote unquote dishonest. These biases influence how clinicians communicate and whether they offer meaningful support, as we can see from previous data. And they can make patients feel fearful, ashamed, and less actually willing to engage. And what we have seen is that patients that feel stigmatized are less likely to actually come back to that clinician for support. This dynamic fosters avoidance, undermines trust, and can deter patients from actually seeking support when they need it the most. Time rigid BMI thresholds served as a gatekeeper to transplantation eligibility. Patients saw these thresholds as arbitrary, as unfair, especially when BMI in their own views was seen as a poor reflection of their own health, function, and also their body composition. Some clinicians agreed, acknowledging that BMI was actually an imperfect measure. However, some clinicians actually felt that BMI cutoffs were a good thing and actually helped people to motivate them to lose weight. And that was really important. Some clinicians also saw that weight loss was even framed as a test of moral worthiness, or quote unquote stewardship for the organ that they were going to receive. Obviously, these combined forces of stigma and BMI-based rules were shaping people who got assessed, got listed, and ultimately received a transplant.